Hi, this is the October 2013 PSEP skills in service on easy IO insertion in the proximal humerus. Before I cover that, I'm going to cover the generalities of easy IO insertions as a reminder. So you can use an IO anytime you need vascular access. That it's starting an IV for the various reasons that it's not your inability to start an IV, so it's secondary to start an IV, but it is your backup when you can't accomplish that. So we want to make sure we cover the rule outs. So when it's not okay to try easy IO insertion. So anytime there's a prosthetic involved that is in the same limb as you want to start your easy IO. So for example, a prosthetic knee and you're looking for a tibial tuberosity site, prosthetic knee in the same leg, that is not okay. Prosthetic hip, the same deal. And there are occasionally prosthetic shoulders, but the prosthesis in the knees and hips is far more common, which is one of the reasons why the proximal humerus is a preferred site. Not the only, however. Trauma to the bone, so if you have a fracture in the same bone that you're starting an easy IO, okay, that's not okay. You're going to get anything you put into that easy IO site is going to leak out that fracture. Your lack of anatomical landmarks. Local infection, you don't want to put an easy IO right into an infected area of the skin, and then an easy IO in the same bone in a 48-hour period. So it takes about 48 to 72 hours for that wound that you created in the bone to heal. And so if you start another IO in that same location, it's going to leak out that hole. Okay, so these are the needle sizes that are associated with easy IO. The pink is pediatrics. And the size range is 3 to 39 kilograms. The blue is what we consider the regular adult size. That's greater than 40 kilograms. And then the yellow is it's actually intended for proximal humerus insertions. That's its primary use, and it's also the bariatric needle, so greater than 40 kilograms. Vancouver Fire carries the pediatric and the yellow, so the red and the yellow, and AMR carries the red and the blue. Now, it's important to make the right needle selection, and part of doing that is to, well, you want to know how deep the bone is in relationship to the skin, so make sure you have the right depth or length of needle to get to the bone. So first thing to do is depress skin and see if you can touch bone and kind of make a guess. So this is an example of an easy IO insertion that will not work out. So you've got more skin tissue than you got length of needle, and as you insert the needle through the skin, you never do touch bone. And in contrast to this one, the illustration on the right with the yellow needle, if you're touching bone, you still have one black needle showing out from the skin, and so that one is a example of a needle insertion that should have positive results. Okay, and once the needle is inserted, there's no need to see the mark post-drive. So this is something that gauges your likelihood of a positive insertion, but not after the fact. You also don't necessarily need to have the hub all the way buried against the skin for it to be in place. So we have 3 sites, 6 options. Proximal humerus. This is the preferred site for adults. So this is your number 1 priority. This is one on adult patients you should be looking for first. Optimal site for high flow and quick drug uptake. Drug uptake is shown by radiocontrast experiments is 2 to 3 seconds before medications get to the heart, so it's into this systemically, it gets into the very rapidly. And for awake responsive patients, it's less painful. The insertion itself has some pain associated with it, but it's actually the flush that hurts. And the reason is because you're putting pressure into that medullary space. And I'll show a little bit some better illustrations of that later. Second, your next site, proximal tibia. This one here is for an adult. Would you be using the blue needle typically for, unless you're in a bariatric patient situation? And then distal tibia. And so if you were to prioritize these, proximal humerus, proximal tibia, distal tibia, in that order. Some site selection considerations. Okay, proximal humerus. So just a little anatomy. We're shooting for the greater tuberosity. As you're palpating somebody's deep palpation of the humerus, you're feeling bone getting to the surgical neck, and then it's one finger line above that as a landmark, a general landmark. And this is something you need to find a partner and practice that. People with more meat on their shoulder areas, it's more difficult to palpate deep palpation of the bone. Okay, there's a couple other landmarks that'll help also. I'll get to those. The hand on the umbilicus, the man illustrated on the right, it's important to have your patient, so we'd be shooting for the shoulder in this case with the hand against the abdomen. You want to put the arm in this, either this position if they're awake, or if they're unconscious, unresponsive, laying supine on the floor. You want the arm tucked into the body with the palm side down. And the reason is because there's a tendon there in your shoulder area, which is actually a good landmark, that if your arm is away from the body or palm outwards, that opens up that notch, so to speak, or that tendon, and you're more likely to put the needle into that space, which would be a miss. Okay, so that's your most likely area of miss in this IO placement. As we illustrate, we're palpating up the humerus to the surgical neck, and we're finding our from there it's 1 to 2 millimeters up from there. Okay, so you want to make sure you correctly identify your insertion point, and your position to the patient is important. So you are oriented to the patient at a 45-degree angle to the patient, from, if you were to consider the anterior plane. And you also want to have a slight angle downward. And so it's the needle, as it's heading downward, you don't get into any growth plates in that way. And so you're 45 to the patient, and 45-degree downward. Advance 1 to 2 centimeters after you feel a pop, and then you want to use a stabilizer. And here's a illustration of a EZAO insertion about to take place. And this is the stabilizer, which Vancouver Fire will be stocking. The needle hub is on the inside of this. On the outside of this is your Easy Connect, which stabilizes the two together. And you're going to have to pull a package apart and actually take a look at that and practice that, so you're not figuring it out on your first patient. But here's an illustration of what it looks like here. Okay. Alright, so flush is definitely important. No flush, no flow. So just remember that. The IO space is filled with a thick fibrin mesh, and you need to kind of break that open a little bit for you to get any type of flow at all. The flush can be painful because you're adding pressure into this space, and this space has a residual pressure associated with it. I'll talk about that in a little bit. But you're increasing that dramatically, and that's quite painful. So that's where the pain is. So in a conscious patient, there's two things you can do for that. If you use lidocaine to anesthetize the area, remember it's supposed to be a local anesthesia and not a systemic push of lidocaine. So that means it needs to be slow, because the shoulder, for example, if it goes systemic within 2 or 3 seconds, you're not going to get a local anesthetic. You're just giving a straight push into the bloodstream. So you want to go slow, up to 2 minutes. Now you're only talking about a couple millimeters of fluid, right? So you know, but in any case, you want to be, don't make that a straight fit. You're not using the lidocaine as a flush. Let's put it that way. And you need pressure to have flow. And the reason is there's residual pressure inside this medullary space, so to speak, of 35 to 25 millimeters mercury. And so just a gravity flow from the bag through the IO is not going to work. You need to put more pressure on the bag than pre-exists in that space. So 50 millimeters mercury, so a blood pressure cuff pumped up to 50 and tightened to stay is something in that range to get any type of flow into that space. Okay, talked about that. And comfort. There are pain sensors, pressure sensors present in that space. The flush causes pain, so anybody who's not unconscious, not unresponsive, is going to feel that, and you're going to need to give some with a local anesthetic and some Versed to alleviate that. So the flush aspiration infusion is that's the area of the significant pain. Proximal humerus is thought to be less painful, or at least by studies it's shown to be less painful. I guess probably less you're not pushing the fluid into this tight of a space, perhaps. I'm not sure. What to monitor and record. So if you start an easy IO insertion, these are things that could be included in the patient's chart, not necessarily all of them, but if they were to occur, there's a list of items to consider when recording your easy IO insertions in a patient chart. Okay, very good. It's going to be important to grab a partner and practice finding your landmarks. Feel free to call training if you need more assistance and on this landmark location, so you feel good about it. But that's it. Proximal humerus easy IO insertions. Take care. Have a safe shift.